Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country. Good morning and welcome to Beats Research Radio. My name is Hallie Arnott and I am the Canadian Biomaterials Society Ottawa Student Chapter President and a graduate student of biomedical engineering at the University of Ottawa. Today I'm extremely excited to be back here as your host on this episode of Beats Research Radio, streamed from an active lab at the University of Ottawa's Heart Institute. Our goal here at Beats Research Radio is to communicate scientific research that's being conducted labs like the one behind me, and how we get from results in a lab and how that makes its way into clinics. What we want to do is be able to give this information to anybody who is willing to listen and show how we go from an idea to results and then to a product that you see either in the market or technology that we use. And also an interesting aspect about our show is that we have early career researchers such as myself interviewing established scientists and so before we get started today, I'd like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society Ottawa Student Chapter, as well as the Beats Research Lab that are supporting us here. And also don't forget to subscribe to our YouTube channel by clicking the red button below this. So today with me, I have Dr. Nadia Khan, who is a clinician researcher and general internist at St. Paul's Hospital in Vancouver. And she's also a member of the Center for Health Evaluation and Outcome Science. While specializing in internal medicine, she focuses on hypertension and chronic disease management, specifically for those in vulnerable populations. Over the past couple years, she has systemically investigated cardiovascular disease burden, acute care delivery for ACS, stroke, and chronic cardiovascular disease management using multi-provincial population-based data sets. Aside from research, Dr. Khan is also a professor in the Department of Medicine at the University of British Columbia. So thank you very much for joining us here today on our show.
Thank you for inviting me.
Great. So do you think you could tell our listeners a little bit about how you became a scientist, how you found yourself working in the cardiovascular research realm?
Great, thank you. So when I was doing my internal medicine program and my medical school, you know, I think like a lot of physicians, I had a lot of questions, you know, and I saw a lot of things that were happening on the ward. So for example, when I would go to the coronary care unit, I would see a lot of South Asians. And when I went into the dialysis ward, which is where there are patients with kidney disease, I saw a lot of East Asians. So questions I instantly had to mind is why is this? Why are there differences? What could be these differences, underlying these differences? And so I knew that in order to try to answer these questions, I needed to do some training in how to properly design research studies, so I could answer all of these questions that were of interest to me and also interest to patients that we were working with.
So you started, I guess, where did you start your medical training? Were you kind of You have your heart set on one medical school, or?
So I was born and raised in Edmonton, Alberta. So I
Okay.
went to medical school at the University of Alberta and also did my residency. And then after that, my husband went to the University of Calgary, and I did my fellowship there and my research training under um, great mentorship with Bill Galley and people who are absolutely world class. Yeah, and started working doing research there as well.
Okay, so so when you were in medical school, what kind of made you decide to go in the research route? Was it seeing those differences when you were on certain wards and those different ethnicities in different wards, and was that kind of that spark that said, oh, I'm interested in research, I want to
Yes.
find out more about this?
Yes, so certainly those questions raised my interest. And also, I had fantastic mentors.
Hmm.
And I think that, we are always the product of the people that we work with. So I was very fortunate to work with really excellent researchers, and they were great role models to me. And I hope that throughout my career, I'm able to be role models for other researchers, budding researchers. But I think that this idea of going to from seeing patients to asking research questions and then trying to apply your results back to patients is so important. So, I think the clinician scientist programs are so important.
Right, doing I guess going from the full, you're doing the full
Exactly.
circle.
Exactly.
So you do focus on hypertension
Mm-hmm.
specifically. Do you think you could tell our listeners a little bit about hypertension, what hypertension is, how you would diagnose it, that kind of thing?
Great. So those are all great questions. So hypertension is another word for hypertension is actually high blood pressure. And what it is that amount of pressure that your blood vessels feel when your heart is contracting, that's the systolic blood pressure, and then when your heart is relaxed, and that's the diastolic pressure. And the thing about high blood pressure is that it's very common. So 1 in 5 Canadian adults have high blood pressure. And if you're fortunate to live to age of 85, the vast majority of people develop high blood pressure. It's the number one cause why anyone sees a physician in Canada, and actually it's the leading cause of death and disability globally. So it's a huge problem for Canadians and globally. And the key thing about high blood pressure is because blood vessels go to every organ, it damages every organ. So it causes cognitive impairment and dementia, heart disease, stroke, kidney disease, uh, aortic aneurysms,
Mm.
and amputations. So
Wow.
there's really wide variety of organs that can be damaged. So it's a really critical issue for us to address.
Right. So we were talking a little bit earlier about what patients with hypertension are wanting from the clinics and wanting from their physicians. And you said that you had done a study that showed what the patients wanted was not exactly what the physicians were providing in terms of, I guess, care and medication, and they were looking for an alternative to medication. Do you
Yes.
think you could tell us a little bit about that and
Yes.
why there might be that
Yeah,
sort of
so we
gap?
did this project where we're there. I think there's more of a shift to really determine what questions matter to patients, and I think
Right.
previously there's always been an emphasis on what are the questions that matter to researchers and the healthcare community, but I think patients have been a little bit left out of that equation. So at Hypertension Canada, we were very interested in trying to determine what is it that patients want, what is the community and the public, not just patients, but the people that look after patients, so their caregivers, what kinds of questions do they want us as the scientific community to answer? And so we had sent out a survey across the country, men and women. We had great representation from rural areas, the Maritimes, et cetera. So it was a really great snapshot of what patients
Mm-hmm.
and their caregivers wanted. And they really had some very clear messages. And one was that they really wanted lifestyle interventions or health behavior changes. They wanted to know what kinds of combinations of activities and diets really can help reduce blood pressure. Although some of that has been studied, they really wanted to know what are the specific combinations and how can it be tailored
Right.
to them as opposed to a cookie cutter approach, a one size fits all approach. And the other interesting thing that we weren't expecting, but probably the public already has a great idea that this is the case, is that research really works at trying to reduce things like stroke and heart disease. And certainly these are still very important to the public and the healthcare community. But what we also found was that patients were very interested in coming off of medications. And generally, we think of high blood pressure, cholesterol problems, typically diabetes too, et cetera, as being sort of chronic, lifelong problems that usually require medication therapy that's also chronic and lifelong. But it was really apparent that they wanted interventions that would try to reduce the number of medications that they were taking and reduce their reliance on drug therapy.
Right. So reducing these medications, it sounds like a great idea, but sometimes it's, you know, these medicinal interventions are extremely important, and they save lives. So, you know, do you think there's maybe a gap in terms of being maybe not informed enough about what the medications do and how that medication is truly helping them? Because I know sometimes, like, if you just take the pill and you say, okay, well, I know it's helping my high blood pressure, but, you know, it's like, okay, well, how is it helping your high blood pressure? Is it, you know, maybe adding or giving more information in that sense that would comfort them a little bit in the sense that, you know, this medication is doing this, you know, specifically. Maybe.
I think that's a great point. And what we did see also is that from those sets of questions, that there was certainly a gap in the amount of information that people are actually receiving. And so, for example, Hypertension Canada now has patient information that patients can receive. Family physicians and nurse practitioners and nurses and pharmacists can download patient information, because I think there's definitely an education gap. And what we've seen in some of the research with the South Asian population, the reason why South Asians and other patients don't really want to continue their medications is because they really don't know enough about why they're taking it, what's the purpose, what are the benefits, what are the risks of those medications. So without that information, it's not easy for the public to make decisions about continuing or starting a medication.
Right. Okay.
But I think it does bring also some interesting avenues for new research. So I think new research looking at device-based therapies or more curative approaches or sort of those kinds of approaches need to be looked at, because the public certainly has this really strong interest in reducing the reliance on medication therapy.
Yeah, like developing an app, you know, showing you can look up one of the drugs and see exactly how it's benefiting you, what it's doing, you know, those types of things are really emerging, and that would definitely be a good solution for that, for sure. So when you're gathering this data, you said all across Canada, especially in rural areas, you were able to gather a lot of information. So this research that you're doing involves a lot of, so it's a systemic sort of analysis. How do you go about completing this type of analysis? It's a lot of information to gather, a lot of information to process, and how do you rule out biases? You know, how does that type of research, how do you do it?
So the thing is that we need ongoing surveillance of conditions like diabetes, high blood pressure, heart disease, and how it's most often done is through national surveys. So the physical measures surveys, the surveys that people will maybe knock at your door one day and ask if they can take your blood pressure, et cetera. So a lot of the information and what we learn about how much we need in terms of resources and what kinds of questions and what areas of emphasis we need to target comes from those surveys. So surveys are really vital. But the problem with surveys, or the limits of surveys, is they're on occasion. So they happen every certain number of years. So there's gaps. The other thing is surveys just are a one-time snapshot. So they don't track what's happening to people. Exactly. And they don't track and link what's happening to that particular patient for years, for example. And you need that kind of information to determine, okay, if they're going to take this medication, what kinds of problems are they going to get? What kind of benefits are they going to get? So that's where administrative data comes in. And really, administrative data is, it's, you know, most, you know, all throughout the United States, and certainly all the provinces and the territories in Canada have administrative data. And this is called routinely collected data that the government actually collects based on hospital visits, healthcare visits, that all go into a data bank that is housed and stewarded by the provincial governments. And this is also a great source of data because it captures almost everybody in each province.
Right.
And so you can actually identify, and we've done this type of work where we've gotten multiple provincial administrative data sets together, pooled them, which is quite a task,
right.
and tried to help determine what are differences between regions, and on large levels we're able to look at, 1 million patients with hypertension, for example, between British Columbia and Alberta, et cetera. So it gives you a lot of power to determine what's actually happening with the public. So that's another source of data. The difficulty in my research area is that certain variables are not collected in administrative data. And that would be, for example, ethnicity. And we know from the United States, who in their administrative data, they routinely collect data on what is a patient's ethnicity. And this is really important because we know that there are different disease patterns for different ethnic groups. It helps us identify which patient populations are more vulnerable, which patient populations are doing well, and that everybody could learn from these different disease patterns. And so that information is not readily available in Canada. So we have to use other methods to try to determine what is someone's ethnicity.
So this wouldn't be part of the survey, I guess? It wouldn't be a question on...
For surveys, yes, but in routinely collected administrative data, it does not have it. So you have to use things like analysis of names, for example, or country of birth, but doesn't quite get at people's ethnicities.
Right, it comes with a little bit of error.
Exactly. So, but that's the state of the current administrative data in Canada. So it makes it a little bit challenging, but there are ways to try to glean important information from it.
Well, so you're able to, with all of this data, you're able to decide, I guess, what you would like to research based on what sticks out, and then you're also able to grab a conclusion from all of this data that you're getting.
Absolutely.
Which I think is great, because when you're one conclusion will then lead to your next study.
Absolutely.
Which is very cool. So, do you think you could tell our listeners a little bit about the South Asian population and identifying this as a different disease pattern? And do you think that this would be the one ethnicity that has a different disease pattern, or are there others that have kind of select disease patterns as well, or is that just one that stands out as being, a little bit different than others?
Yes, great question. So we had been studying the role of ethnicity in development of disease, for example. And in particular, we looked at South Asian and Chinese populations, descent populations living in Canada. And we certainly did find that these groups had different disease patterns. So for example, South Asians tended to have more high blood pressure, high rates of diabetes, high rates of kidney disease, heart disease, and ischemic stroke. Whereas the Chinese pattern, Chinese descent patients living in Canada, they tended to have more hemorrhagic stroke, which is a bleeding variety of stroke, which is quite a serious problem, and also had increased rates of high blood pressure as well. But they were actually getting lower rates of heart disease. So the disease patterns differed. And in Indigenous and First Nations populations, their disease patterns also differ, again, with higher rates of type 2 diabetes, obesity, dyslipidemia, kidney disease, for example. So there are different ethnic patterns in which group is going to get which disease compared to the other groups.
And this is important to find out, because it helps you, and it helps physicians determine how they're going to treat the patient, because of all of these different avenues that could have. This person is more likely to have this problem, or this person is more likely to have this problem because of this sort of area that they're in. And I think that's a great way to treat somebody. That's great.
So we found, for example, that South Asians in particular, and South Asians mean people that have descended from India, Sri Lanka, Pakistan, and Bangladesh, for example, they have higher rates of diabetes, but they're also getting diseases and these cardiac risk factors at much younger ages.
Okay.
So we did, for example, a study to see, how young are these diseases occurring in these populations, and we looked actually at children and youth from age 5 to 30, and we found that South Asians' risk of type 2 diabetes started to really take off after the age of 15.
Oh wow, that's
so
young.
By the time that they were in their 20s, they had much higher rates of type 2 diabetes than other patient populations. So we're really understanding that diseases and ethnicity makes a really substantial difference. And then later on, we were looking at how does it affect their care. So we know that it affects the acquisition of risk factors and the acquisition of heart disease. But how does it actually also affect care? Because we know that Canada is a highly diverse population. And so there are a lot of people of different ethnic backgrounds that are interacting in the healthcare system. And do we understand enough about how different ethnic populations manage their disease, and in fact, are there differences in how they manage disease that would affect how we deliver care? And so we were researching this as well, and found certainly there are really significant differences in care as well. Not so much in the care delivery at Canadian hospitals and by Canadian physicians, but mostly on how South Asians and Chinese manage their disease and understand their disease.
Right. I think this is an extremely important realm of research, because telling or explaining to someone how they can manage their disease, like we were talking about, that Canadian study, is something that patients are interested in. So we will get back with Dr. Khan here in just a few minutes, but we're going to take a short break. Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country. Good morning and welcome back to Beats Research Radio. Today I have Dr. Nadia Khan sitting in with me, who is a clinician researcher and general internist at St. Paul's Hospital in Vancouver and a professor in the Department of Medicine at the University of British Columbia. So to get back in with our conversation here, I'd just like to ask you a little bit about the healthcare differences for disease management and how different ethnic populations manage their disease, and if there's a difference in how one would manage their disease versus another.
Yeah, so we know that there are differences in risk factors such as physical activity. So South Asian and Chinese populations living in Canada tend to exercise much less than the general population. And so also the other aspect is that when they do develop risk factors like high blood pressure and diabetes, they're much less likely to continue on with their medication. So we usually call that term medication adherence. Right. Their medication adherence is quite a bit lower than the general population. And it is bad even for the general population, but extremely poor in ethnic populations.
Okay.
And the thing is that we know that ethnic groups in Canada visit their physician just as often as the general population. So it's not because they're not seeking care and not having touch point interactions with healthcare professionals. They are having all of those, but they tend not to continue on with their medications.
Right, so the continuing on with their medications, would that be completely not stopping taking the medication, or would it be maybe forgetting or not being consistent with taking it?
Perfect. So what most definitions of not being adherent mean is that in order to get the full effect of a medication, you need to take it at least 80% of the time. Okay. So you're kind of given that up to 20% leeway for occasionally forgetting, but really in order to reap the benefits of the medication, you need to be taking it at least 80% of the time. So non-adherence is less than that.
Okay. So do you think that because these people are seeking the medical advice and they are going to their doctors, is it something that is happening on the care side then, and we just have not figured out how to go about and how to help these patients manage their disease? Is that where it's coming from?
So I think that's a great question, and adherence is complicated, and it's usually also having to do with the healthcare provider, the patient factors, and also system factors. So for example, costs of medications. So if the costs of medications are high, it really reduces adherence in the Canadian population. That's why I think there's a strong push for a national pharmacare program of needed medications. And then the other is care provider. So even though we see care providers prescribing medications, but again, what we were talking about earlier in the segment is that patients don't necessarily have the understanding that we think they do about the benefits and the risks of the medications, and how to take them, and all of these kinds
all the information,
critical information, exactly, that the patients and the public need to understand in order to really buy into the medication. So we know that communication between providers and patients makes a difference in whether or not anybody takes their medication. And then there are some factors from the patient's end. So if forgetting, for example, not having an established routine, general beliefs about medications. So a lot of the Canadian public actually do not believe in Western medications.
Okay.
They would much rather take a natural therapy, a supplement, than say a blood pressure pill or a diabetes medication or a cholesterol pill. They have concerns about what are the effects of those medications. There's some degree of inherent mistrust. That's not everybody, but that's certainly an important proportion of the public.
People.
And this is even more emphasized in the South Asian community.
Okay. So I guess we would need to be more transparent in terms of what the medication, what's inside the medication. I guess in today's market, there's a growing increase on what the consumer wants and what they want to see on the label and how a product will do in the market. So I can see how that would translate to medication as well, and you needing, you wanting to know what you're taking and what's in the supplement or what's in the medication would be an important for the consumer.
Yes, I think that's very true. I think that they want more information about the medication, and then in order to really buy into taking it.
Right.
And then also, I think you brought up a great point about transparency, and I think that it's important if patients aren't feeling well or they're having side effects with their medications. Sometimes people just stop the medication, but I think it's also important to talk to your care provider about issues you're having with the medications, be it cost, be it adverse effects, or concerns or questions about your medications. It's important to discuss it, because I think the problem is a lot of healthcare providers do not know that people are non-adherent.
Okay, yeah, it's a two-way street. It's what the care provider can really only help you as much as what the information you're able to give them. So
that's right.
It's definitely a both sides sort of scenario. Also, do you think you could tell now our listeners a little bit about how these systemic studies and how your research on hypertension can be extremely beneficial for the population on a very large scale, and how gathering all of this data and analyzing it can provide these patients with better care at the end of the day?
So understanding the surveillance aspect of high blood pressure, diabetes, stroke, heart disease, and drilling down at some of these causes, like why are we seeing these? We had done, we were interested in these questions about how do different ethnic groups manage their disease, for example. And so monitoring afterwards, we were able to identify things like South Asians, for example, were being referred less for cardiac rehabilitation.
Okay.
Then this issue of medication non-adherence and beliefs, and all of those things help you target interventions or ways of trying to solve that problem. So this all gives greater understanding for scientists. And for example, we created an intervention trial called the Namaste trial for patients with type 2 diabetes who are South Asian, trying to really, all of these factors that we had understood from all of the other data that we had collected on high blood pressure, diabetes, heart disease, and how they were having struggles with managing, struggles, as I mentioned, with engaging in physical activity, struggles with identifying what's the right diet, their knowledge base, all of those things, and struggling with adhering to medications. So we really worked on those in this in a very culturally tailored way, addressing some of the belief systems that these groups had. And then we're almost done recruiting for that study. It's 600 patients, and I think we're at 525 now. So we're getting close to the end of that study. So we'll really be able to see whether or not interventions directed at these ethnic groups, trying to get at some of the deeper cultural factors, actually can make a difference in their care.
Right, and I guess the answers that you get from one ethnic group can lead to answers for another because of the different links that one might have with another.
Absolutely. So one hypothesis is that families can play a larger role in helping with disease management. So right now we know from surveys that family members often are informal caregivers of patients, but they themselves don't know exactly what to do for their family member to help them manage their disease. And I think a lot of people can relate to having either a family member telling them to do things that may or may not be helpful, but telling them to do things, and also as a family member struggling with what can you do to help people. So this is something we found in the South Asian population. So a part of our trial was to actually to identify, can you have family members working very specifically and in a targeted fashion to try to help their family member. And I think if we find that those differences are beneficial, that would be something that we could bring to other groups, the general population. Those kinds of interventions might be helpful for a broader range of people.
Right, and for elderly patients too, having a family member who can be an advocate for you.
Absolutely.
And also a family member who is able to possibly translate in certain scenarios, because there are language barriers in some sense, as well as for the aging population too, having an advocate who can be there is also great. So a family member is helpful, I guess.
Yes, so there's sort of your in-home or in-neighborhood support system that we could be leveraging more. But that's an example of how research from ethnic groups can help translate to a broader population and maybe a benefit to a broader population. And different things like different elements of diet or physical activity that were found useful in one population may also be very useful in other populations. So, for example, the Mediterranean diet that has been adopted in many different groups, that was predominantly more seen in the Mediterranean area. So that's another example about how looking at different what different groups have to offer, and again helping the broader population.
So do you think in Canada, is there a main challenge when it comes to hypertension management and prevention for those, or prevention of hypertension for those vulnerable populations? Is there one? I guess it's a very difficult question to answer because it could be a number of things, but is there one thing that sticks out more than others?
I think there's a few, and I think it's also impacts the entire population. But there is a significant issue with unawareness of high blood pressure, and this is mostly occurring in younger men, working age men. And so there is a significant population that has high blood pressure, requires medication treatment to prevent heart disease and the development of kidney disease and all those complications we talked about at the start of the hour, and they actually don't know they're hypertensive. And that's probably because they're not seeking medical care. These are the people that are working and they tend not to see physicians. So that is one key issue, is trying to improve unawareness in that patient, in that subgroup. They are in a way a vulnerable population because they don't seek medical care.
Right, and is there maybe a telltale sign or something to look for for that population, if we were to give some advice maybe?
So the challenge with hypertension is often called the silent killer. So it is actually asymptomatic, but there are ways of screening at your pharmacists, at your pharmacies, at some fire halls have blood pressure screening kiosks, and also different clinics, will screen people's blood pressures, or even purchasing a home blood pressure cuff for screening and really looking for those elevated numbers, greater than 140/90 in most people, or 135/85 using your home monitors. So those kinds of numbers should trigger someone to see their doctor, or their nurse practitioner or their care provider. The other is getting blood pressure under control in everyone. And so we find that actually elderly women are more likely to not have their blood pressure controlled. And we know that elderly women tend to have higher rates of stroke. So given that high blood pressure is the most important driver of stroke, it's really critical that we get, that's another subpopulation of people, that a vulnerable population that we need to work on.
And yeah, staying on top of your own health and being proactive and
Absolutely.
Finding solutions is great. And also just having an advocate in the family, someone who, because in my family, my sister's a nurse and she likes to put the blood pressure cuff on everybody and go around and check and make sure everyone's okay.
That's
so
perfect.
It's definitely something, even though you might not be in the age group that would be hypertensive, or it's good to just to know what your health is.
And the Hypertension Canada guidelines recommend that all adults, and even they have guidelines for children, but all adults should have their blood pressures measured at every appropriate physician visit.
Right.
So it's really important that we do more surveillance, because I think we now need to look at how can we prevent hypertension from happening.
So the tools that would be helpful for that, the tools that would be helpful to mitigate this challenge possibly would be going to the pharmacy, going to those fire halls maybe. Would there be other possible tools that we would, that we can take to possibly, help this scenario?
Well, I think those are the best ways of trying to identify whether or not screening for high blood pressure. And then the other important part is if you or your healthcare provider thinks that you have high blood pressure, is to make sure you have some sort of out of office measurement, because those are much more accurate than office measurements, to try to determine whether or not you have high blood pressure or not.
And taking the measurements consistently too, because I guess it would change depending on the time of day, depending on what you ate, or lots of different factors.
That's right.
The blood surveillance, even just on your own surveillance, is extremely important.
Exactly.
Okay. So what would you say the long-term goal of your research? What you're looking for on the broader scale, what you're looking for on the horizon, something that you're working towards?
So as I was telling you about that Namaste trial, so we're going to be concluding that trial, and that was really to answer the big question about whether or not addressing culture in a very deep and meaningful way, leveraging some of those factors I was mentioning, families, peer support, improved education, makes a difference. So is that how we should be managing high blood pressure and diabetes, for example. And a lot of organizations, including the WHO, Diabetes Canada, Hypertension Canada, they've all asked that we need to have culturally tailored programs to try to help some of these vulnerable populations. But we really don't know how to do that. So I'm hoping that this research may help shed some light on exactly how can we deliver that culturally tailored care that would be effective, cost effective as well. And then the other aspect of research that I'm hoping to do, sort of at the conclusion, is more of these patient-centered research projects trying to help with healthcare delivery, so it is delivering the care that the public wants and that the public needs, and how we as healthcare providers can be more responsive to what the public is looking for, and how that might help with healthcare delivery, because we have a lot of research on what is effective, and then the challenge is implementing it. So we could have all of this investment in research, but when it actually comes to the patient, how do we get then the next hurdle, having the patient reap the benefits of all of this research? So that's sort of my area, is trying to make sure that all of these interventions that we know about, the blood pressure medications, the monitoring, all of the devices, that they can be really optimally implemented in the public, so that they reap all the rewards.
So it's providing those tools to the patient and making sure, and also for the healthcare providers, so that there's a, making that two-way street a little bit easier to get across.
Exactly.
So do you think you could tell us a little bit about maybe a finding that you recently, or maybe a systemic review that you've done, or something recent that kind of popped out and you said, oh, that is different than what I thought, or something that was interesting?
So we had just finished a study that was published in Hypertension, and it was looking at using the SPRINT data. So it was a large hypertension trial in the US, and we were actually asking a question that the public asks me all the time as a hypertension specialist, which is, well, do you think my blood pressure could be too low now? Now you've treated it. Is there a bottom number where it's now too low and it's harmful for me?
Right.
So we actually want to evaluate this, and we actually did study that and found that blood pressures below 60 millimeters of mercury for the diastolic actually were too low and started to cause increased cardiovascular event rates.
Okay.
So we weren't really able to tell that before because studies typically didn't bring people's blood pressures down that low.
That wasn't.
So this sprint trial gave us a great opportunity to find that. So that was really an interesting finding that we hope is helpful for care providers.
Okay, very cool. Thank you very much for coming in to our radio show today and giving our listeners a little insight on your research and hypertension and everything that you're doing for the scientific and medical community. So thank you to all of our listeners as well. Also to the University of Ottawa Heart Institute, eLife, the Canadian Biomaterial Society, Ottawa Student Chapter, and Beats Research Lab, who are supporting us here. Don't forget to subscribe to our YouTube channel, and we will see you next week. Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.